So when to consider preventive treatment, I would say, there's a lot of rules of thumb that people have, but if it's impairing their quality of life despite the use of acute medications, that's a good time to start it. If you're having more than 3 moderate to severe headache days per month and acute medications aren't working, that's a good way. I have 2 ends of people. I have, like I talked about my aquarians, they have a headache 24/7, 30 days a month, and they still don't want medicine. And I think that's underkill. And then I had like some really type A judge type personality, and he had only 2 migraine days a month. But for him, it was the worst thing in the world. And he's like, I can't miss 2 days of work per month. I'm falling behind. And so he wanted to start a preventive that day. So I tell people, there's no hard and fast rule of thumb. For me, it's somewhere between 4 to 8 headache days per month, and it's causing a functional impairment. But ultimately, it's a decision that the patient reaches with you after talking about, pros and cons and balancing the options. So the goals of prevention: you want to reduce attack frequency, severity, duration. You want to reduce the associated symptoms like nausea, light and sound sensitivity, improve responsiveness to your acute medications, improve their function or like get them back to work, even if they still have a little bit of headache, reducing the cost of like emergency department visits, the patients are using taxis to drive instead of things, and preventing disease progression. This is a bit controversial, but the thought is if you leave migraine untended, it can get worse over time. In the trials, we look at mean monthly migraine days, and that's our prime metric. But to be honest, that doesn't capture all the other types of disability and other ways that these can improve their quality of life. So that's why I think some of the newer trials are looking more at patient satisfaction and work function and life function with family and home.